There's a lot of confusion and misconceptions about the differences and similarities between hospice and palliative care. Though they both focus on improving quality of life for patients with advanced or serious illness, there are a couple of important distinctions. The first is that you do not need to be dying to receive palliative care. Palliative care is appropriate at any stage of a serious illness, from diagnosis forward. The second is that you do not need to give up curative treatments to receive palliative care. Palliative care is appropriate alongside curative therapy, including chemotherapy, radiation, or other treatments for serious illness. There's a very high prevalence of uncontrolled pain in this country. Looking at the SUPPORT study, which was a study of more than 9,000 patients at 5 academic medical centers, more than 50% of patients had moderate to severe pain in their last 3 days of life. There are a lot of different barriers to adequate pain management, but one of the great barriers is that patients and physicians are afraid of opioid medications. I'm going to spend a couple of minutes talking about some common myths related to opioid medications. The first myth is that opioids are too addictive for practical use. In reality, addiction to opioid medications is very rare. The exception to that is patients who have a history of former substance abuse. The medical literature focuses on cancer patients and tells us that if a patient's pain abates, we can easily and safely taper off these medications. Opioids do not fundamentally change people. The second myth is that the risk of respiratory depression is too great with the use of opioid medications. In fact, respiratory depression is very rare when these medications are used appropriately and cautiously. Opioid medications have even been shown to be safe in a population of patients with respiratory illnesses. In fact, for patients with COPD, opioids have been shown not only to improve dyspnea, but also to improve exercise tolerance in this patient population. The third myth is that patients will rapidly develop tolerance to opioid medications and require escalating doses. In fact, tolerance to the analgesic effects of opioids is very rare. If a patient on a stable dose of opioids requires sudden escalation in doses, the physician should consider disease progression or a new problem. PULSed stands for Physician Orders for Life-Sustaining Treatment. The PULSed program was initiated in response to patients receiving medical care that was inconsistent with their wishes. The goal of the PULSed program is that patients' wishes are followed regardless of care setting. The PULSed form is a medical order form used to write orders for life-sustaining treatment preferences for patients with serious illness. The form translates the values, goals, and wishes expressed in an advance directive into a medical order that does not require interpretation or activation. The form stays valid across treatment settings. The PULSE program was signed into law in New Jersey in January of 2012 and is currently being implemented across the state.